Good afternoon, everyone. A very warm welcome to all of you. I, Dr. Muskan Alawa, thank all of you for joining us here for this insightful virtual session on emerging trends in first trimester testing, from screening to definitive diagnosis, by Metropolis, a center of excellence for women and child health. The session is organized by Voice of Healthcare in association with Metropolis Healthcare, with the main objective of fostering meaningful dialogue on the evolving landscape of first trimester screening, prenatal genetics, and some evidence based decision making in clinical practice. We are delighted to have an esteemed panel of experts with us today who will share their clinical insights, experiences, and perspectives through real world case scenarios. So, at this point, I would like to hand over the session to our moderator, Dr. Talat Khan, a senior consultant and doctor in charge of medical genetics global reference laboratory from Metropolis Healthcare Mumbai. So, ma'am will take it forward and initiate our today's discussion. Over to you, Dr. Talat.
Yeah. Good afternoon, everyone. A very warm welcome to all the esteemed faculties and the participants joining us today. Welcome to this session on emerging trends in first trimester testing from screening to definitive diagnosis. The first trimester has increasingly become the golden window for prenatal care. Advances in ultrasound, biochemistry, and genomics not only allow us to identify the risk earlier, often before the symptoms are arising, but then the management and the counseling options are becoming the widest. However, with these advances, we do have to see the balance versus in screening versus diagnosis. Are we over relying on the technologies, and how to translate complex results into meaningful counseling which is patient centric? In this session, we aim to set the context for how the first trimester testing is evolving from traditional risk assessment to a more definitive diagnostic pathways. Through the expert insights, we will explore what is evidence based, what is how clinicians can responsibly integrate these tools into everyday practice. We are delighted to have a
We
distinguished...
lost Dr. Talat's sound. Was she audible to everyone?
Yes, she is audible.
Okay, all right.
So, ma'am, we are delighted to have distinguished experts with us today, and we look forward to an engaging and clinically relevant discussion. Join me in welcoming our esteemed panelist, Dr. Mala Arora, founder, Indian Recurrent Pregnancy Loss Foundation, and Vice Chairperson, International Associate for Recurrent Pregnancy Loss, and leading expert in recurrent miscarriages and pregnancy care. Welcome, Dr. Mala. Dr. Purnima Ramesh, consultant obstetrics and gynecology in Ashwini Clinic, Bangalore, specialized in high pregnancy and laparoscopic surgery. Welcome, Dr. Purnima.
Thank you very much.
Dr. Manu-Rathi, a director, Mumbai Fetal Medicine Center and senior fetal medicine consultant at Surya Mother and Child Hospital, Santacruz, Mumbai. Welcome, Dr. Ashwini.
I am very sorry, but I can't hear Dr. Talat. I can hear the other participants though. So can I log back out and back in?
Yes, ma'am. You can just drop once and log back. It's fine.
Dr. Talat is audible to everyone. Like now I can hear you, Dr. Muskan. But is Dr.
Yes,
Talat,
ma'am. Dr. Talat is audible.
to everyone?
Yes, ma'am.
All right.
I think there will be some technical glitch. It's okay. You can drop once and join back.
All right. Okay, sure. Do that. Okay.
Over to you, Dr. Talat.
Dr. Rukkayal Fathima, a consultant obstetrics and gynecology reproductive medicine expert from Motherhood Hospital, Chennai. Welcome, Dr. Rukkayal.
Ma'am, sorry to interrupt. I couldn't hear you anything, ma'am. For past 10 minutes, there is I couldn't. No audio is also there. I couldn't hear the person speaking also. From my side, signal is okay, ma'am. I don't know what the problem.
Can you hear us right now?
Yes, ma'am. Now I can hear you.
Are you able to hear Dr. Talat?
No, ma'am. I couldn't hear Madam Talat, madam's voice.
What could be the...
Dr. Ashwini, are you able to hear right now?
I can hear you speaking. If Dr. Talat could say something, I can.
I also
now.
the same thing.
Good afternoon, Dr.
Now
Ashwini.
I can hear you. Yeah.
Ma'am, now I can hear Talat, ma'am. But now I can't.
Okay. Sure.
Right.
I think there was some network issue. That's fine. Please continue.
All right.
So we would like to welcome Dr. Ashwini Rathi, the Director, Mumbai Fetal Medicine Center and Senior Fetal Medicine Consultant at Surya Mother and Child Hospital, Santacruz, Mumbai. Welcome, Dr. Ashwini.
Thank you. Thank you for the greetings. Thank you.
Dr. Rukkayal Fathima, she's a consultant, obstetrics and gynecology and reproductive medicine expert at Motherhood Hospital, Chennai. Welcome, Dr. Rukkayal. I am Dr. Talat Khan, a consultant pathologist and the doctor in charge in medical genetics, global reference laboratory in Metropolis Healthcare, Mumbai. And I have the privilege of moderating today's session. We will now move to the real world case scenarios that reflect common dilemmas faced in daily practice. Each case highlights challenges across screening, diagnostic, and counseling, and with the help of various evolving technologies. Our first case is a 29-year-old primey, which is 11 weeks and 5 days. Combined first trimester screening shows low biochemical risk. However, ultrasound reveals an increased nuchal translucency with borderline CRL measurements. The patient is quite anxious and believes NIPT is diagnostic and is reluctant to continue to consider the invasive testing. So in this case of 29-year-old primey, Dr. Mala ma'am, this case highlights a bit of uncertainty. So why is first trimester screening, first trimester period increasingly considered as the golden window for risk assessment, particularly from a miscarriage and a genetic risk perspective?
Can't hear. I can't hear her speaking.
Yeah.
No, we can't hear Dr. Mala Arora. Maybe increase the volume, I think.
Sorry, ma'am, we are not able to hear you.
Unmute.
Yeah. So in the interest of time, we can ask Dr. Purnima ma'am, when the biochemical screening appears reassuring, but ultrasound shows some red
Can't
flags.
hear Dr. Talat again. Is that a problem with
Yeah.
others?
I can hear the Talat. Can you hear me?
I can't hear other
Yes, ma'am.
participants at all. Dr. Purnima too, I can't hear.
Don't know. See, when the
Ma'am, can you hear
biochemical.
me? Dr. Purnima ma'am, can you hear me?
Yes, I can hear
Yes.
you.
Yeah.
Yeah. See, when the biochemical screening is saying reassuring and the NT is high, it depends upon how much of the NT is abnormal. So, especially in the patients less than 35 years with the borderline NT like 3.5 to 3 to 3.5, we can take NIPT maybe reassuring. But if the NT is very high, that is more than 3.5, it has been noted that there are certain conditions. The very fact that the NT is high, that it indicates that lymphatic abnormality. It can be a feature of one of the feature of Down syndrome. But there are other conditions like cardiac abnormalities, Noonan syndrome, skeletal dysplasia. These are the things which cannot be diagnosed with NIPT alone. So a very high NT, about 3.5 mm, especially in younger women who is less than 35 years, we cannot discard that it is Down syndrome and be happy with only NIPT. So it warrants a detailed cardiac anomaly scan and other genetic methods to rule out all these conditions.
Okay. So having mentioned about NIPT, ma'am,
Yeah.
Can you hear me now?
Yes, ma'am, we are able to hear you. Your voice is a bit low, but we are able to hear you,
Okay.
ma'am.
Okay. So do you want me to say
Yes,
something
ma'am.
on
So
this
actually,
case?
yes, ma'am. So actually, as this case highlights a bit of uncertainty, why is the first trimester screening considered as a golden window, particularly from a miscarriage and a genetic risk perspective?
So a lot of miscarriages are genetic, and it is the first trimester which gives us the opportunity to screen the fetus for genetic abnormalities. The other advantage of first trimester is also to screen for preeclampsia and to screen for late pregnancy complications like IUGR, because the frequent assessment by ultrasound genetic markers as well as biochemical testing or NIPT would lay the foundation of how that pregnancy is going to progress in the future. And I agree with Dr. Purnima that NIPT is important in this case, but does not tell you everything, because there are many causes of nuchal translucency which are non genetic. And even if NIPT is inconclusive, we will have to resort to invasive testing before we take any definitive action in this pregnancy.
Yeah. So, given the current Indian and international guidelines, as we talk about NIPT, how appropriate it is to prescribe NIPT instead of combining first trimester screening or quadruple screening, especially in cases like this?
So, the American college states that NIPT should be offered to all, but in a poor resource country like India, we are unable to offer expensive testing, and combined first trimester screening is still a very viable option in a lot of our patients. Every pregnancy has to be screened, definitely. And I think uh, because of the awareness of NIPT, a lot of patients will come and ask for it. And it becomes difficult to protect yourself in a court of law. We recently had a case where combined biochemical screening was normal, and then the baby had an abnormality, and they said, "Why didn't you offer us NIPT? We would have done it," and terminated the pregnancy. So I think we have to put everything into consideration. It should be offered to all those who can afford it, and then let them decide whether they wish to go ahead or not.
Yes, ma'am, very rightly said. I was going to ask Dr. Ashwini regarding the same thing, that many couples nowadays they are very learned and they believe NIPT is 100% diagnostic. So, Dr. Ashwini, how do you counsel such patients, and with what common misconceptions about Down syndrome and NIPT and screening do they frequently come to you in your clinical practice?
Right. Yeah. Hi. So, just a small additional information on the previous point. So, increased NT has to be taken into consideration with respect to CRL. So there is no particular NT where we say it is, abnormal. So this number 3, 3.5 is very frequently quoted, but many a times an NT of 2.8, 2.7 also will be abnormal if the CRL is smaller, say at 48, 49 CRL. So always correlate NT with the CRL and use the centiles. So that was one point. Coming to the misconceptions about NIPS. So the word NIPS, the S stands for screening. So that is the first thing that I tell all couples, that it is a screening test. It is not diagnostic at all. It has very good positive predictive value for Down syndrome, to a lesser extent for trisomy 13, 18, to a much lower extent for sex chromosomal aneuploidies. Therefore, it is not a diagnostic test. The advanced NIPS that is being peddled by a lot of labs with deletions and duplications also. Again, they are not completely. Uh, they are not being identified everywhere. So again, I don't rely on those. So I usually will do only the standard NIPS. If anything more I need, it will be invasive testing. So I always tell them that it is a screening test and not diagnostic.
No.
Second, I tell them that if there is any problem on the sonography, there is increased NT, there is an absent nasal bone, or there is a cardiac problem, NIPS is not required. They will need an invasive testing. So NIPS cannot be looked upon as a substitute for amniocentesis or CVS.
Right.
So in a very small spectrum of cases, and NIPS, of course, for everyone can be done, but when there is a problem on the sonography, the invasive testing is a must. And a lot of false positive cases we do see for especially sex chromosome aneuploidies on NIPS. So if NIPS comes high risk, that is the next thing that I tell them. No need for terminating that pregnancy. They need to be confirmed with invasive testing because a lot of patients feel that, oh, NIPS high risk aa gaya, so, there is no hope for us. But it is screening test. It needs to be confirmed.
Right, ma'am. So this case clearly shows us that how early ultrasound findings, patient perception, and test limitations always intersect. Right. So let's move to a second case scenario. 34-year-old G2P1 undergoes a early fetal scan at 13 weeks, showing subtle soft markers. Her previous pregnancy had normal 20-week anomaly scan. In the current pregnancy, she has a history of vanishing twin and is requesting an expanded NIPT, including microdeletions due to anxiety. Now, Dr. Ashwini, based on your experience, how does early fetal screening compare with the traditional second trimester anomaly screening in detecting suspected genetic conditions?
All right. Okay. So now a couple of points in this case. Vanishing twin by itself is more or less a contraindication for NIPS.
Yeah.
So the general guideline or the dictum is that 6 to 8 weeks after the fetal pole of the demised fetus has been, not seen, only then NIPS can be considered valid because some amount of the DNA of that fetus will still be in the maternal system. So in vanishing twins, we are not talking about NIPS generally. Then second point was advanced NIPS. I already covered. They have not been validated, the microdeletions, duplications. Therefore, how much we can rely on them, I don't know. So in my practice, I don't usually advise NIPS advanced. I stick to the basic because Down syndrome is my major concern. Third point, how does early screening do in comparison to anomaly scan? That was the question, right?
Yes.
Uh,
Yes.
so, of course, early screening is doing very well as far as the Down syndrome is concerned. So, if we have our NT and dual marker combined, we are as good as 95% detection rate with a false positive of 5%. If we add NIPS to it as a screening test, we will do very good for Down syndrome. So, we of course don't have to wait till anomaly scan. Anomaly scan will, of course, give us a structural assessment, but our first trimester screening is very good for, especially for Down syndrome. And of course, other genetic conditions also do show up, but of course, lesser than Downs in the first trimester. But now with advanced sonography on the transvaginal, we can pick up cardiac defects, etc. So other genetic problems also we do explore. But for Downs, first trimester screening is the standard.
Dr. Rukkayal, according to your clinical experience, how do you look at the expanded NIPT, especially microdeletions, especially in IVF and donor oocytes? Dr. Rukkayal? Yeah. You are in mute, Dr. Rukkayal. Yeah.
Can you hear me now?
Yes.
Yeah.
Yes.
See, See, in advanced NIPT is still in the kind of consideration stage, as well as it is yet to be validated. And in most of the situations, such as the donor oocyte program, I still feel the early pregnancy scan, which with the double marker screening, it still holds good. The utility of expand NIPT in these scenarios hinges on detailed pre-genetic test counseling, and we just have to weigh certain criterias actually as such. And the criterias do include, and we have to ask a specific, whether we are looking at some targeted risk assessment, and we have to understand the limitations of the test as such, especially the low positive predictive value, and then the necessity of an invasive confirmation too. So it has the strongest rationale in the donor oocyte pregnancies, where maternal history is absent. It cautiously considered in IVF pregnancy and is generally not recommended in vanishing twin too. So it is a tool that can provide a valuable information, but must be integrated into a careful diagnostic pathway with an expert guidance in order to avoid harm from kind of misinterpretations.
Yeah, that's quite insightful. So, Dr. Ashwini, with improved ultrasound guidance and operator expertise, how do you see the role of CVS today compared with early amniocentesis? Is the hesitancy still driven mainly by fear of complication or placental mosaicism? What is your opinion in your clinical expertise?
All right. So, if you have to compare CVS and amniocentesis,
Yeah,
there
yes.
is, according to me, there is nothing like an early amniocentesis. So, CVS is done before 14 weeks of pregnancy. Amniocentesis is done after 16 weeks of pregnancy. Why we don't opt for amniocentesis before 16 weeks? The increased risk of amniotic band, limb defects, etc. And also the amniotic fluid is not that much that we can very easily aspirate 20 ml. So we stick to amniocentesis after 16 weeks and CVS before 14 weeks. CVS, the advantage, of course, is that you will have your results, and preferably you might have a first trimester termination option, though by the time the results come, you're almost touching 13 plus 14 weeks. But otherwise, both the procedures are almost the same. Risk of miscarriage is quoted in the publications to be the same at around zero point 0.3 to max 0.5% for either CVS or amniocentesis. CVS as a procedure could be slightly more difficult, especially with a posterior low-lying placenta compared to an amniocentesis, but in expert hands should not be a problem. Confined placental mosaicism, yes, that is the only difficulty with CVS. In my 13 years of practice, I encountered it twice. So it is rare. But if it happens, the only thing that we have to do is call the patient back again for an amniocentesis. So aneuploidies is something that, the placenta can have a different sort of a genotype, and the fetal cells could be different. So in those cases, we call them back again for amniocentesis and avoid terminations based on the report of the CVS. So confined placental mosaicism is the only disadvantage to the CVS, but it is rare, and there are ways to get around it, that is to the amniocentesis and prove that the fetal karyotype is normal. So overall, CVS is a good option if you have a high risk result in the NIPS or first trimester screening, so that they have the early results and option of closer first trimester termination rather than waiting again all the way till amnio.
Exactly. Well, thank you. This case highlights how advances can be always taken with a word of caution. So now moving to the recurrent pregnancy losses in IVF planning. Now a 32-year-old woman with two previous early miscarriages is planning IVF. She wants to know whether she qualifies for an RPL workup and what investigations are truly required and whether IVF changes her management. So, Dr. Mala ma'am, what are the current ESHRE recommended diagnostic criteria for recurrent pregnancy loss? And Which additional investigations have become relevant when IVF is being planned?
Yeah. So ESHRE recommends that 2 or more pregnancy losses qualify for a complete RPL workup. Now, as you know, RPL is multifactorial. And so looking at just the genetics does not give us the complete picture. We have to investigate by an anatomical scan, either a 3D or a sonohystogram, to see whether the patient has a normal uterine contour, any septate uterus. We have to do screening for APLA syndrome by all the 3 tests, which is lupus anticoagulant, beta 2 glycoprotein 1, and anticardiolipin antibodies, IgG, IgM, because these are very preventable causes of recurrent miscarriages. We also have to look at if previous products show a genetic problem, we should do a parental karyotyping to check for balanced translocations. And now we are adding a few more tests to this list. One is anti-nuclear antibodies to rule out autoimmunity. And especially if you take a history and the patient has a history of autoimmunity, that is when we should do an anti-nuclear antibody, and to look at the male partner with sperm DNA fragmentation index, because that can equally contribute to a miscarriage. Then there are tests like hormonal tests like thyroid, which is routinely screened, thyroid and antithyroid antibodies, serum prolactin, and we also have to look into their lifestyles to eliminate any factors like exposure to dry cleaning chemicals or smoking or drug intake, which can contribute to miscarriages. So, certainly before IVF, we need to do a comprehensive screening of the couple. That is important. With IVF pregnancies, where the time to pregnancy, I think in the RPL couple, we are also worried about how much time do they take to get pregnant again. In a young patient who is in her 20s, the time to pregnancy is shorter. But if you have a patient who is 35 and above, needs IVF, then even your threshold to investigate her becomes lower than even 2 miscarriages, because you don't have much time to get her pregnant. So that time to pregnancy is also an important consideration.
And ma'am, what about the other relevant investigations like HLA or factor V Leiden mutations? How commonly in your clinical practice do you investigate patients for these?
So, one is the thrombophilia gene mutations, and there is a lot of controversy in literature whether they should be investigated in first trimester miscarriages. Of course, in later stillbirths, they become more important. But there is now increasing evidence that if the thrombophilia gene mutations are present as multiples, like if there's a factor V Leiden associated with a prothrombin gene deficiency or a protein S deficiency, if there are 2 or 3 thrombophilic factors present in the same patient, then they become important, and these patients do well with anticoagulant medication throughout pregnancy. So again, it becomes a more of a history based, if there is a family history of vascular thrombosis, past history, you would lean towards investigating more for thrombophilias. And if not, then perhaps that can be omitted. ESHRE guidelines don't recommend it at the moment. But if we are doing it, there are 3 important ones. One is the prothrombin gene, the other is the factor V Leiden, and the third is the MTHFR gene, which has 2 variants. The 1298 is not as important as the 697 gene mutation. In my practice, I do a homocysteine testing, uh, because that also leads us to a factor MTHFR gene mutation. If the homocysteine is high, it points to the fact that this patient needs anticoagulation. Now, there are multiple reasons for homocysteine to be high. One could be folic acid deficiency, could be MTHFR gene mutation, or it could be familial or drug induced. Western literature and ESHRE do not recommend homocysteine testing, but in our population, in the last almost 40 years, our RPL database shows that at least 30% of the patients with recurrent miscarriages have high homocysteine. And it is a comparatively less expensive test than doing the thrombophilia gene panel. So that can be offered to nearly everyone to screen for those that need anticoagulant therapy.
Mhm.
Okay, that was quite insightful and a reminder that more testing needs to be done with proper counseling, and it is always a case-based approach. There's no formula which will apply to all. Yeah. Our
Absolutely.
final case looks at a post-screening abnormality and a future genomic pathway. A 36-year-old pregnant woman receives an abnormal screening report suggestive of aneuploidy risk. She's offered a karyotype microarray and an exome testing while her counseling was done. She questions whether her prior PGTA should not have already ruled this out and asks what future technologies may change the care. So, Dr. Poonima ma'am, how do the approach of prenatal genomic testing or screening in IVF, donor egg, and surrogate pregnancies happen, and how do you counsel such couples who have already undergone PGTA and are advised further prenatal testing?
So it is a very comprehensive question where I would like to make it to part by part, especially when the patient is already looking at PGTA and they have done it. They have to be counseled when they are offered PGTA itself. That even after the this comes as normal after the implantation, and she has to be tested for routine prenatal testings, which are applicable to every patient according to the ESHRE and guideline also. They said that every patient who undergoes ART should be offered all the routine screening tests. And they should be counseled that in a PGTA, we are looking at the cells which are not a part of the cells which are going to be a fetus. That is the trophectoderm. So that is why during the, and also there can be an error rate of 1 to 5% where we can miss the abnormality. So for all these reasons, we have to counsel them that in spite of having a PGTA, it is not a this 100% confirmation. So during the baby also might get some other chromosomal abnormality during the development. So it is prudent, and also it should be emphasized that she has to undergo the routine prenatal testings and genomic testings after the pregnancy, and and also as directed by the routine things like as we are discussing for the first trimester, second trimester, and also some genomic tests are guided by the ultrasound findings, and also what we are expecting through the ultrasound, what anomalies are expected, and what appropriate genetic testing has to be done according to that. And more than, in case of surrogate pregnancy, it is the mother who is we have to do the routine screening, like carrier screening is very, very important, especially for example, hemoglobinopathies is one which is very, very common, and that has to be offered. And also the recipient also should be offered the routine prenatal testings.
Right, ma'am. So, as we have discussed the strengths and limitations of current first trimester screening and diagnostic tools, I would like to ask another question for all our panelists. Like, after an abnormal screen or scan, which tests do you personally consider as a first line, and why? And do you see any timeline wherein the whole exome sequencing may be able to replace the CMA in more routine practice? Like looking ahead, among emerging possibilities such as organ-specific cell-free DNA, AI-assisted ultrasound, which pathways do you feel are realistic, scalable, and clinically responsible for near future? We would like to know the perspective from all our panelists. We can start from Dr. Mala, ma'am.
Yeah. So currently we are doing whole exome on amniotic sampling only when karyotype does not give us a clue and there is a structural abnormality. There is, or if there is a family history of an affected child, you're trying to locate where the problem could be. But I think, as with parental testing with karyotype, we now have definite indications for doing whole exome in the parents as well in unexplained cases of miscarriage where you have odd products of conception showing kind of odd results or genetic mutations. Similarly, for the amniotic fluid as well, it is an expanding field where we will be seeing more of whole exome sequencing on amniotic cells to make sure that we are dealing with a chromosomally normal or genetically normal baby. Because a lot of single gene defects are now implicated in both miscarriages, stillbirths, late pregnancy losses. So it is definitely the test of the future will take over um, microarray as we refine it more and learn how to interpret the results better and have a close the gap between the financial implications of CGH and next generation sequencing.
Thank you, ma'am. Dr. Punima, ma'am, would you like
Yeah,
to
there
share
is
some
no
insights?
single genetic test which is covering everything. That is one thing they have to be told. And it is, for example, if you are looking at some uniparental disomy and other things, some of the things you have to do appropriate tests like MLPA. And it depends upon, it is directed by what abnormality you are looking at. For example, if there is a mental retardation or a learning disability in the family, it is the trio sequencing which is very, very important. So each genetic test has got its own validity, and not that everything can be detected with everything. Everything cannot tell. So by and large, we are for chromosomal and aneuploidy, and with little more, we are using PMA. And as Madam said, that whole exome sequencing is coming up in a big way. It is helping us to counsel the patient, counsel the family, and the future probability of getting an abnormal baby. But that is also it has got its own limitation. So, having gone through the genetic training in ICMR, more and more we read and we feel less and less we know about it. And there is no definitely one particular test. What is offered by some of this, there is a group of tests. For example, if you are looking at skeletal dysplasia, there is a group which you have to choose, and you have to first and foremost thing, the genetic counselor should be involved in this and give them the clinical scenario so that they will be able to help us in detecting or choosing an appropriate test. That is the most important thing in this particular one. There is nothing uniformal or one test will tell everything. More and more, if we do the of course, the whole genome sequencing is not yet clinically available. It is still the research one. But even if we get it, we are thrown with so many information which we cannot handle. So it is the next part will be the how to tell the patient whether everything is important, whether how much is clinically going to be useful to you. So it is
Yeah, would
always
be
associated with the genetic counselor. We will have to offer them, and depending upon what problem you are looking at.
Yeah. It is an extremely relevant clinical point, actually, especially to the Indian context.
People
Dr.
think that
Rukkayal,
mirror, mirror, show me everything means everything will be shown in the genetic testing. It is not so.
it is not.
Dr. Rukkayal, would you like to share some insights on this?
See, I think for whole exome sequence to completely replace CMA, it should take some more time, because technically sometimes I feel, see, this is out of my experience. Whenever I send for many of the anomalies, no, this CMA will identify the causative CNVs in that. So instead of that, if we perform a more expensive whole exome sequencing upfront in all cases, no, it would increase an incidental finding and that variant of unknown significance in most cases. But in many cases, I don't end up in a proper diagnosis as such. That is my opinion. And generally, whole exome sequencing as a standalone test, I don't think so. It will replace CMB. My main thing is it should be having an integrated genomic platform that will provide a concurrent, sometimes when we have a CNV and then a sequence analysis that is from a single sample, that will help us in as a first line for complex fetal anomalies. That should be coming as a validated one, except in cases like I don't think so whole exome sequencing alone might be little costly also, and we might not get what we expect. But again, as madam told, it is we have to counsel them adequately and offer them what we want. But over a time, in my personal experiences of lot of IVF patients and anomalies, I have felt that CMA definitely can be better when compared to whole exome sequencing as of present.
And another thing, when we are looking at recurrent pregnancy, now certain things are seen only in the gametic abnormality. In those cases, it is the product of conception which is going to give you a lot of information than any other parental testing. See, this is how we have to,
Absolutely.
depending on the clinical scenario, you choose the test. So
No, if the
another thing is,
products,
if having every 6 months that there is an advancement and there will be whatever is this one of unknown significance may become significant. So it is important to tell the patient to keep that, that's what we call it as a BAM file or something, which they can request the geneticist to keep it. So after certain time, if there is an advancement, probably whatever was unknown significance may become pathological or significant one. So they can relook into that same genetic file. That
material.
information will be useful for the patient rather than reinvesting in that.
No, if your products are the first line testing, but there are many, many patients that come to the clinic where the products have not been tested, they have had three miscarriages, and you really don't know where to begin with them. I've had patients who've had after IVF or even spontaneously 3, 4, 5 biochemical pregnancies. So you know that something is not right and you need to investigate. That is when we look at the parents more closely, when we have missed the opportunity of looking at the products. But otherwise, I totally agree, Dr. Purnima, that products should be your first line testing. They're easier.
If it is available.
Yeah. Dr. Ashwini, ma'am, would you like to share some insights in your clinical practice?
No, I completely agree with whatever has been said so far as whole exome is concerned. So whole
Yes.
exome is being touted as like the next big thing that will solve all problems. But again, personally, I also don't think it throws up a lot more questions than answers. And at least whole exome, then try your whole exome along with the parents if needs to be done. But otherwise, the next test that I feel practically very useful is the RH antigen on NIPS. I mean, if you're asking which is a scalable and a doable test for RH negative mothers. So, knowing the fetal blood group on the NIPS is the next good
Yes,
test that
yes.
I am looking forward to, and I've used, and it's so far worked quite well. So, RH antigen on NIPS would be my next test to look forward to. Otherwise, for anomalies, currently, microarray high resolution is what I would prefer, unless very specifically whole exome, and then at least in trio, we can send the sample. But otherwise, whole exome cannot be touted as the solution for everything because there is too much complexity in genetics that already prior speakers, Dr. Purnima Madam has covered. So NIPS RH antigen would be my next sort of to
Yes,
look out
it is
for
not
test.
uniformly available. We have been
But
trying to
that's
do
what,
only one or
huh,
two places
true.
only it is
Two
available. It
labs
saves a
are,
lot. Yeah, it saves a lot of
yes,
trouble.
Yes,
Repeated
yes.
yes,
Doppler, because
mm,
especially they have to come from rural place, one test will
correct.
solve their problem.
Sort out
Even
all the
and
problems. Yeah.
yes,
Yeah.
So the labs which I've worked with, fortunately, I have not had a problem. Fetus has turned out RH negative only where they have reported as RH negative, but that will solve a lot of problems. The unnecessary anti-D that is to be given, a whole lot of confusion about ICT, the testing timings, then CAPSP Dopplers.
Dopplers, NPA
So
Dopplers, two
yeah.
weekly Dopplers.
Mhm. Yes. So that is my go-to test to answer your question. I mean,
Yeah.
look forward to.
Yeah. So as we are talking about availability of the tests, I would like to ask all the panelists that how the tertiary laboratories like Metropolis best support the clinicians in the rapidly evolving space. I'd like to encourage all of you to reflect not only on technologically what is possible and not, but also on what is clinically meaningful and ethically sound for our patients. Starting from Dr. Ashwini ma'am, as you spoke last in the
Sorry, but can you repeat the question? I mean, it was a little long and
Yes, ma'am. So
yeah,
how
a
can
very long question.
tertiary Yes, ma'am. So how can a tertiary lab like Metropolis best support clinicians in the rapidly evolving space?
All
And
right. Okay. Yeah. Understood. Yes. Yes. Okay. So, a lot of responsibility lies on the labs because many clinicians use the labs representatives as their sole point of knowledge. So the labs have to be very responsible in what they are marketing. Things like a common example, advanced NIPS is marketed so aggressively, but it is not validated. So labs have to take up that responsibility. They don't have to be commercially driven and they have to give the right information that is validated, accurate, up to date to the clinicians. So, in that way, the labs can certainly help clinicians.
Can I tell my point? See, so many times this thalassemia screening has been spoken in every conference. But if you go and ask a clinician how many of you are doing it, they say they're not doing it. 90% of I can say that they are not doing it. Having taken actually the government of India has also had taken clear the problem of thalassemia. It is not possible, but every one of us should be doing the thalassemia screening. You include that as a part of the antenatal profile by default by or promote that. That is a very doable thing, and it is very important to do to look into it, because 99% of the reports what I see, nobody would have done thalassemia screening. So it's
Right.
a very simple thing to do, but it goes a long way for the patient. The how much they go through that if they are thalassemia positive and a major problem. And it is not uncommon to find so many cases of thalassemia. If you start doing the screening, you will realize that so many patients are thalassemia free, and all kinds of thalassemias I have seen, including alpha thalassemia, of course, which cannot be done with a simple thing, but we will get to know through the family history. But at least beta thalassemia, we have to be doing it. You have to aggressively promote that and make sure that everybody does. That is my desire, and I want everybody to do it.
Okay.
right, Dr. Mala ma'am.
So I had 3 points in my mind how the labs can help. As earlier Dr. Purnima said, can we have a genetic counselor involved in deciding which test is best done for a couple? Because, as you said, these are expensive tests and you don't want to go into the wrong lead. So that is one thing. Secondly, if I know you do store DNA once we send it for testing, because especially in the RPL population, many times when we send you the sample, the patient is not interested in paying for the test. But once they get pregnant again, they come back to you and say, "Oh, we want to know what to do now, and then you say, oh, it is important we look at the genetics of that baby. So storing DNA should be a service that I would want these labs to offer at a bare minimum cost, which the patients can afford. And thirdly, it is important that the labs can offer you the scaling up of the test in a particular package. Like if you have done a karyotype or a CGH microarray and you've not got an answer and you need to go on to the next test, the patient as the clinical level feels, why is this doctor telling me first to do this and then to do this and then to do this? I think if there's an automatic scaling in the desired population and you are the best people to decide, then the clinician and the patient feel very happy that when it is everything is good, you can do away with just doing a karyotype or a microarray, and when things are not very clear, you automatically can scale up to provide an answer. So I think there is a huge gap, where we want the obstetricians to understand the genetic tests, and there is a huge scope for conducting programs to educate the genetics. I think if we do something like training of trainers and then kind of disseminate this information, we have done one such through the RPL Society, and I know the gap is huge. I don't think even one particular branch can fill it, just the obstetricians. I think everyone has to come together. The geneticists, the obstetricians, the labs, the pharma has to come together to have these teaching programs so that we can educate the obstetricians.
Exactly,
And
madam. I mean,
Yes, Dr.
yeah,
Rukkayal.
yeah, I was supposed to. I was thinking about it because I've had a great problems with the counseling. I mean, the counseling support has to be really be there. It's bridging the lab, clinic, and patient gap. That it exactly, because sometimes we need a dedicated genetic counselor whenever we have to offer direct access to these people, especially lab affiliated genetic counselors. Sometimes it is very important to discuss complex reports, some test selections at all. Whenever we want to do some test, it is better to discuss with them only before going ahead with the test. So to discuss with them the option, and then sometimes the interpretation is too complicated. Sometimes we can have an opinion with them, and then develop. Also, I would sometimes want to, in case of genetics, sometimes I will feel some kind of explanatory videos, pamphlets that is be given by the lab. If it is given to us, it will be easy. Of course, many of the time I send it back to my fetal medicine consultant, but sometimes when the patient keeps on asking me about the next level of testing, how the CMA, sometimes there have been patients incidents where they've asked me about the CMA, WES and all. So if there is some kind of pamphlets and some pictorial representation, it will be really good. So to precisely, there should be a decision support phase that should be offered by the lab, that is a pre-test, and during the test also an assurance phase, and when the report will be coming in, and the knowledge translation phase is very important. Once a test report comes, in case of complicated situations, it will be better there's a knowledge translation phase. So immediate GC backup, to report back, and joint counseling sessions will be very much needed. And beyond these tests, of course, the continuous learning loops will help us in a greater way too.
genetics have really grown in with the leaps and bounds, and it is really, really difficult to keep up with the progress. And having undergone 1 month training in ICMR regarding the genetic, right from how they do the karyotyping, what all the things go into it. At the end of 1 month, also, yes, I can counsel the patient better, but still, it is not enough. You definitely need a genetic counselor, and the knowledge is too much, and the availability is also too much, and this will be much more in the future. So there should be a process where you have to educate the clinician, especially with the usage of different kinds of genetic tests which are available, where it is appropriate, when to use what. So this basic knowledge should be disseminated to every clinician, especially obstetrician and gynecologist and fetal medicine specialist.
Yes, ma'am. Actually, Metropolis has already, taken the pulse of this, and we are very soon we'll be launching a clinical support vertical in this. So, in which the genetic counselor will be there at the clinic, and rightwise you said it. All of you mentioned the point of, having a genetic counseling support, dedicated ones, or day wise. So this we are already working on this, and in the future we will be having this clinical support vertical with dedicated genetic counselors on board.
Okay.
So thank you to our distinguished panel for translating this complexity into clarity. We will now take a few questions from the audience. Dr. Muskan.
I have two questions in the chat box and I can quickly answer them.
Yes.
How do you early reassurance versus aggressive intervention? Well, in patients with RPL, I think it is best that we do our testing prior to their getting pregnant because a lot of the interventions need to be started early. And if we are trying to investigate them once they get pregnant, we often lose the window of treating them. So I think anybody that has a miscarriage should be called to follow up so that they can be investigated in the interpregnancy interval. But if that doesn't happen, I think it is very important that we run at least the blood tests all in one go, like the APLA screening, the anti-nuclear antibody, the homocysteine, um, and all other the hormonal profile all at the first opportunity. And then we will have to do away with anatomical assessment of the uterus because that is not possible. And secondly, if you've had unexplained early miscarriages, then it is important that we do this whole battery of testing before the patient gets pregnant. And it's now believed many times that in the thrombophilic population that has a thrombophilia gene mutation, you may need to start the aspirin early, pre pregnancy. In the autoimmune group, you may have to start the HCQ 3 months pre pregnancy to keep this complement levels optimum. So I think it is very important that all these tests should be performed in that population. Thank you.
I have one question. When the first trimester red flags appear, is timing more critical than the test selection in preventing the adverse outcome? See, this I wanted to check. One second. See, in the first trimester, this is my observation. That double marker test, it is more sensitive earlier in the around the 10-11 weeks. Whereas the NT, it is very difficult to do at 11 weeks. It is better at 12 and 13 weeks. And though the traditionally the books say that it is the CRL, according to the CRL, where 45 to 84 millimeter is the cutoff value, 13 weeks and 6 days. For several years, I have been pestering Dr. Suresh and others because if you put a CRL of 76, it will that software will show that it is 14 weeks. So it will go out of this one. So then I had to sit with Dr. Suresh, and when he met Dr. Nicolaides, and he said that no, 84, though it is given CRL, it is originally there is some problem. It cannot, the software where you send it for combined testing will not support that 84 if you take the CRL. So to go in a middle path where the sensitivity of double test will be very less, nearing 13 weeks, and it is very difficult to I mean above 76 CRL, it is very difficult to give a combined test report where the software is not going to support. I feel that 12 plus weeks will be the ideal time to do the combined screening, where you have not lost the sensitivity. The sensitivity and the specificity of the test will be ideal. That is what my opinion. It's a personal opinion, and also I have discussed with Dr. Suresh, and who in turn discussed with Dr. Nicolaides.
I would like to add here. Okay, there is a question also for me, but ma'am, Astrea does support
Yeah,
whenever
not
even.
everybody is using
uh,
Astral, this
but
one. So,
for example, all of us who are doing NT scans do have access to the Fetal Medicine Foundation software. I mean, that is free, which we can all download. So it is accepting CRLs after 76 also.
mhm,
And in fact, all labs uniformly will accept
mhm.
CRLs after
Yeah,
76
that's
to
what
84.
lab, if it is FMF, this one, most of the labs will be FMF
Yeah,
accredited
so the
to be issued.
CRL till 84 is accepted for combined first trimester screening.
Mhm.
So
Because I
that's
use
one.
Mediscan system, this one, the moment I put 76 CRL, it shows 14 weeks.
But still, it will also generate a risk, basically. I mean, that's
Mhm.
the take-home message that I would want to say that till
Okay.
84, I mean, lest they, feel that they can't do it only after 76, so let that message not go
Yeah, that's
across.
what, yeah,
Till,
that is not
huh,
my idea to do that.
huh. Correct,
Um,
correct, correct.
this was my observation. That is what I
Correct,
was
correct.
telling.
So till
And
84, it can be done and the results will be given. So if I can go back to the question that was flashed. What is the single most important ultrasound finding in the first trimester that should prompt immediate diagnostic testing? So NT above the 99th centile
percentile.
would be my answer. So anytime the NT is above 99th, definite diagnostic testing. Between 95th to 99th, it will depend on other factors. Her past history, what else we are seeing on the sonography, is the nasal bone also absent, is the heart looking abnormal, etc. Uh, but anything above 99th centile, definitely diagnostic. Other, we will need to, case to case, we'll need to decide.
The next question is not directed to any particular clinician, but yes, in ART pregnancies, how do you prevent the genetic overtesting driven by anxiety rather than clinical indications? Dr. Rukkayal, would you like to take this?
Yeah. In case of ART pregnancies, nowadays, um, people do ask for genetic testing well ahead when they come for counseling at all. You this question means the pre-transfer genetic testing, right? Pre-implantation genetic testing. That is what you're trying to ask, right? Can I get the
Yes,
question?
ma'am.
How do you prevent genetic over testing driven by anxiety rather than clinical indications? So I take it as in ART pregnancies, in case of once the embryo is created, the PGTA is most, I mean, nowadays I'm practicing in a city where if I get around 10 IVF pregnancies, patients, at least 8 of them do opt for PGTA without me counseling. Sometimes the indicated patients would have been one or two, like an recurrent miscarriage or kind of karyotyping abnormalities. But generally, others too, they also feel that they want to go ahead with the PGTA just to make sure that they are everything is sealed and still success happens. In spite of explaining them about the pros and cons, the invasive PGTA, the further testing that could become positive, the epigenetic changes, they are even more anxious to do it. And but sometimes a detailed counseling only will help us in overcoming this. About the real time percentage of how many euploid embryos we get, and sometimes how many of them do end up in first trimester changes, and then how many patients we subject to further testing too. So I try to avoid doing PGTA if it is non indicated in most of the situations. But of late, even I feel that patients do exert that kind of pressure over us, and we I somehow had to offer it. But only by detailed counseling and telling them the facts about that there are chances of a second time, transferring a euploid embryo alone does not guarantee 100% success in kind of ART procedures. But there are a lot of other factors too that are involved. So such kind of counseling would help them to overcome the anxiousness and prevent such kind of genetic testing unnecessarily.
Great insights by Dr. Fatima. So I think with that we'll conclude our today's session. So Dr. Talat, would you like to say something on the closing remarks?
Yeah, I would like to thank all our esteemed speakers for the valuable time and enriching deliberations and our attendees for the active participation. First trimester testing continues to evolve rapidly, taking us from screening to more definitive diagnosis. And today's discussion has highlighted exactly how can we integrate these advances into our routine practice. Thank you once again and wishing you all a wonderful evening.
Thank you.
Thank you,
Thank you so
Dr.
much,
Talat.
everyone, for joining.
Thank you so
Thank
much.
you.